Welcome back to Clinical Communication. My name is Ben. I'm a specialist physio and clinical communication skills facilitator here in the UK. And today I'm delighted to be speaking with my good friend, Jack March, who is a rheumatology specialist physio and also the director of operations at Physio Matters. Today we'll be discussing the various discussions and conversations you'll have with patients with osteoporosis, osteoarthritis, or inflammatory arthritis, covering from assessment through to management and making a plan. You can find Jack online by searching for Rheumatology Physio into whatever social media you use. I'm at BY Physio on whatever social media you use. If you find this useful today, please do share it with others. Please do let me know what will make it better or what you'd like to discuss or hear next time or guests to get. Thank you for watching. Enjoy it, and I'll speak to you next time. What is the, obviously you and I have a similar musical taste. What would you say is the average rheumatology department musical, if there was a stereo playing in the background?
It would be Radio 2. Whatever's on Radio 2 would be the rheumatology departments I've been in. That's what's usually playing is whatever's on Radio 2. So it sounds of the late 80s and early 90s, I reckon.
You say what you tweeted me this before we started, that you were listening to Disturbed to prepare for this.
I was listening to Disturbed. I was sitting waiting for you to come onto the Zoom, and I was thinking about you playing the bass guitar, and that then Disturbed was what triggered in my mind. So that's what I typed in Spotify, and then it went on to some other of my musical tastes, My Chemical Romance and stuff.
You know what? That's the only musician in their band they've changed is the bassist.
Is it?
Everyone else, yeah, the guitar, drums, singers all the same. Do you have a top 3 Disturbed songs?
My top one particularly is Sound of Silence, the Simon and Garfunkel cover. Really like that. Yeah. Then Down with the Sickness for certain. And then I don't know if I could give a third one off the top of my head. I'd need to look at their song lists because it's all in your ear now, isn't it? You're not looking at the track listings. So I've lost a lot of track names from my memory, but those are definitely the top 2.
The amount of extra downloads they must have got when COVID started, and all those reels using the Down with the Sickness song, and how much I don't know how much money they actually make off those things, but the amount of extra downloads they'd have got thanks to COVID probably
exactly. It was like when we're going way off topic now, aren't we? But Stranger Things played there was that song, wasn't there? And I've blanked it. There was a Stranger Things song, and I've forgotten the lady's name that sang it. And she was making sort of millions a week.
Yeah.
Do you remember that?
Yes. Is it Kate Bush?
Over the hill, I think. Kate Bush, yeah, that was it. And she was making, because they were just millions of downloads as soon as that episode went off. Shit, they were making loads. So, but they usually, I don't think Spotify pay very well, do they? But anyway, here we go.
Thank you for doing this, by the way.
That's right. Pleasure.
Very kind of you. And I've already done your introduction in the recording before. And obviously people probably don't want to sit and listen to us talk about Disturbed all night. So I should probably ask.
They should.
I put up an April. This was a few months ago. I put up the April Fool's joke that Rob and I were going to do a Metal and Physio podcast, and I actually got messages from people saying, "When is this coming out?"
Yeah.
When are you starting? So yeah, they've. Well, who knows? We'll see. If enough people message us and tell us they want it, then I guess we can do it, can't we?
Maybe metal might be a bit specific. You might have to branch to sort of rock or something, but
yeah, that's probably, yes, maybe, yeah, rock and who knows? We can work it out. People message us enough, we'll do it.
Yeah.
I should probably ask you some clinical stuff because that's what we're here for. And I know you've obviously got this new osteoporosis course. Is out now, or is going to be out?
Yeah. Low bone density, I've called that. And yeah, that's been out. What are we now? We're recording this late August. I think it's been out about 6 weeks, maybe.
Okay, grand.
I planned on releasing it in September and ended up with some time I wasn't expecting and got it finished early. So yeah, it's been out a bit.
Excellent. So I'll start with that osteoporosis. That's very relevant, recent to you. I'm going to save all the clinical bits for people to go and learn on your course. That's okay. So they can learn about what osteoporosis is and how to diagnose it and all that jazz. But if I give you a scenario, if we've got 65-year-old Florence has come in to see you. She had a sudden onset of back pain after falling onto a very gentle fall. She's happened to go to A&E and they picked up a wedge fracture. And you, being a very proactive clinician, suspect this may be a osteoporotic fracture, organised a DEXA scan. The FACT scores come back as osteoporotic. She turns around to you and says, okay, what's that? What do we say?
So so I tend to front end these conversations with I tend to ask the people what do they currently understand, and they quite often will say, oh, nothing, I don't understand anything about it, and then I'll follow up. I try to get them to give me a starting point. So us, I use questions like, what's that mean to you, or have you heard of that before, to try and gauge some of their language, some of where they're at with understanding the process. So if she says, oh, it means I've got brittle bones or something like, it gives me somewhere to begin. And then I might follow up. Sometimes I do, sometimes I don't. I might follow up with, how much detail do you want? How much information do you want? We don't have to go through it all now. How much understanding do you sort of feel you need for this? But then I go on to describe, I'll sort of describe how bones have an inherent structure to them. And that can obviously be either stronger or less strong. And it's about how resilient those bones are to fracturing. It doesn't cause any, if you've got very low bone density, it doesn't cause you any symptoms. It just means that you have a higher likelihood of having a fracture, or a lower trauma will cause a fracture, which wouldn't normally have done or wouldn't have previously done. And I'll try and bring that to what's happened to them. So for her, for example, I would say, whereas for a 20-year-old version of you, it might have taken falling down the stairs to have this kind of fracture. For you, you just needed however she fell. You fell off your chair or whatever it was. So I try and relate it to what's happened. But then what I always make sure I do in these scenarios, especially in low bone density, these kind of frightening, scary type diagnoses where they go, oh my God, I don't want to do anything now because I'm gonna get fractures. I try and gear quickly towards the positive. So I'll go on to say things, like, there's a lot we can do to stop the bone density getting worse. There's medications, there's exercise, there's dietary changes we can do, and if we improve your balance, then it's less likely you'll fall over, and we can do these kind of things, and we'll, there's a lot of processes we can go through to reduce the likelihood of this happening again. And I'll always try and say to people, everybody is at risk of having a fracture, for example. How many professional athletes do you see who've got broken legs, broken arms, whatever? It just means that we need to put strategies in place to make sure that you get back to a bit more towards normal, or what we would consider normal. So I always say when I teach my courses and stuff, I'm always like, if we have to go somewhere scary, I go as quickly as I can through the scary parts, with the understanding that they need, into a reassuring place. So I don't leave them with a scary thing. I try to leave them with a reassuring thing. I think that's probably my approach as best I can, really. I wouldn't claim to be sort of an expert at doing that kind of thing, and it's harder with some people than other people, for sure. And some people are just resilient as hell. It doesn't matter. They're the easy people to sort of talk to, for me anyway. Then other people they're going to be scared, and you're not going to fix that quickly.
You said about trying not to scare them or get through the scare a bit quickly. What you didn't say there, which I still hear patients say, is the Swiss cheese model. Ditch it, or is there better analogies to use in this day and age than that?
Yeah, I try and stay away from analogies. Um, I find there's such a risk of them going wrong. You know, you commonly you especially the work that I've done, so the latter part of my career, latter part, it's not like I'm going to retire. The sort of the second half of my current career, I suppose, where I've been in more diagnostics than I have been in rehab. You just don't get that so much time to get to know people and build that rapport and understand how things are going to be received. So I try to stay away from it. I try to go with more factually accurate statements. So what I'll say is, you know, most of your bones, so I quite often use the thigh bone as the biggest bone. Most people know the femur in their thigh, and I'll say, you know, so the inside of that is made up of what might be like scaffolding. So you've got crisscrossing bars of scaffolding, and they give your bone the structure. So you've got the outside part of the bone, you know, like you see on a chicken bone, it's sort of shiny and then you've got this scaffolding structure. You've got these bars within, they make like a honeycomb structure. And what happens in low bone density is either one of a few things. Either you get less of those bars, but they're still the same size, or you've got the same number, but they are not the same size, so they're skinnier bars, or you get a combination of the two. And the more of one or the other or both, then you get an overall loss of density. So then the bone is more likely to fracture. So that's how I go out. That's how, and I don't feel like that takes me very long. You know, I don't feel like it's like, that doesn't save me any time to be like, oh, you've made the Swiss cheese holes bigger. Like, it doesn't save me much time, but it allows me to go through that. And then what that allows me to do then is, when you go on to then talk about the management strategies, loading, vitamin D, calcium, the bisphosphonates, for example, to lay down bone, then I'll be saying, you know, you put a stimulus through the bone, and those scaffolding bars, they respond to that, and they will get bigger. Now, that's not biologically completely accurate, but it's a decent description of what happens on a biological level. Does that make sense?
That makes perfect sense. Certainly, I'll be honest, I've never heard someone being told, patient come in, being told the Swiss cheese model, and then feel more reassured or more safe or whatever. It's never had a positive benefit to them. Certainly, even if just the word scaffold certainly sounds more supportive than Swiss cheese, if all else.
And you know, that to be honest, that's purely accidental. That, to me, they seem like scaffolding bars. It makes sense in my mind. They happen to be supportive as well. You know, I think that's accidental. I like it. And it's very rarely have I had a negative reaction to that kind of description.
The term, obviously, we will have people come in and being told or looked up that they've got brittle bones because they've got osteoporosis. Again, a term to avoid, or
I suppose the job is, I suppose they technically are brittle. You know, I was laughing the other day. Sidebar slightly. Laughing the other day. My wife's watching Bones, the TV program from the late anyway. But they keep going on about green stick fractures in adults. They don't, it's right, like, you don't get green stick fractures in adults, or not, mostly you don't get, it's not a normal thing that would occur. Something metabolic's gone wrong if you're going to get soft bones and get a green stick fracture. So that's not really what's happening. When we lose that structure, internal structure, they are technically brittle. So it's not that they're wrong. I agree, it's a scary term, but it's also not incorrect. So I'm not like, oh no, don't think of them as brittle, because equally, let's say someone is osteoporotic and their bone density is really quite low. Sort of, while I don't want to scare them, I also don't really want them risk taking either. You know, so just use a stupid example, you know, I don't want them going skateboarding or something where they're likely to fall over. And again, I take this sort of approach when we're talking about loading. It's like, well, the loading types are relatively similar in their effectiveness. So I go towards, you know, I say to people, look, you're safe. You can even lift heavy weights, but what we want to avoid is falling over. So if, you know, box jumps, for example, are just as effective as lifting a heavy weight because you're gaining the impact, you're stimulating the bone, but you're far more likely to fall over on a box jump than you are in a deadlift.
Yeah.
Whereas I think the perception is that a deadlift, for example, is dangerous because you're including probably some spinal flexion, you're bending forwards, you're lifting. Whereas actually the data would say that's not dangerous to you at all with low bone density. But box jump, you're likely to fall. I'd fall over within about 2 goes. So, probably doesn't matter to me. My bone density, I hope, is pretty normal. But if you've got low bone density, you're going to get a wrist fracture, you're going to get a clavicle fracture, whatever. You're going to suffer a fracture if you fall over. So again, it's this sort of, yes, there are bad things with this. We can't sugarcoat it that much. But equally, if we weave this into a reassuring, this is how we're going to manage it type discussion, that's how I try and steer the discussion, if that makes sense.
And let's say, as you say, you've had that discussion, you've discussed management options as well. You've even said, if we put aside anything that's going to cause another fall or trauma, and she turns around to you and says, well, at this point, anything else I should avoid now, apart from those things, is if she says that, what is she just no, or is there anything else she should avoid?
No. I mean, it's the main problems are going to be falling or being hit by something. The being hit by something is likely to cause you to fall over. The other thing would be loads you are unaccustomed to. So, if I've forgotten the name of the lady,
Florence.
Florence, I was close.
Florence.
You can see why I don't do extended rehab. I can't remember anybody's name. If she comes in and she never lifts anything that's very heavy, then no, don't go lifting 20-kilo bags of compost. Let's rehabilitate up to that. But if she is regularly gardening, she's regularly lifting stuff, this is absolutely fine. So it's the unaccustomed stuff, then yes, we should ease into that. But that's the same with anybody, anybody that doesn't lift heavy weights. If they go and lift heavy weights, they're going to have some sort of problem if they're unaccustomed to it, short term, long term, whatever. So that's the only other thing that I would say. And then I tend to make a joke about being hit by a bus. That's usually I make that joke far more often than I probably should.
I don't think you're the only person that makes that joke either. I think,
no.
I think most probably would. And before she takes that on board, she's got a plan ready. Before she walks out the door, she turns to you, she says, "Is it curable?"
Yeah, hard answer that. So unfortunately, it isn't really. So there are a lot of improvements that can be made. Some of the drugs do cause an increase in bone density, but most of them just stop the deterioration. So it's all about the exercise over a longer period of time can increase bone density to a degree, but it's not, you're not, to put numbers on it, you're not going to go from a minus 2.5, which is your diagnostic cutoff in a DEXA scan for osteoporosis. You're not going to go to 0. You might get to 2, you might get to even 1.5, you might have some proof, but you're not going to get huge increases. So I talk about, we give you the best opportunity to resist the trauma, the falling, make you as fit and as strong as possible. We optimize you as best we can, and that will reduce, we know that reduces the risk of fracture, which is different to the bone density. So I tried to explore that, some people I'll talk about, a minus 1 on the DEXA scan is still normal. So that's lower than average or lower than expected. So your bone density is technically low, but at that point you're not at particular increased risk of fractures. So you need some other components to cause that as well. So either much lower bone density or this very high risk of falls. And sometimes I'll say, think about people who might be really at risk of falling, but they have normal bone density. If you drink far too much, far too often, and you fall over 100 times comparative to someone else who falls over once, who's going to be more at risk of fracture? The person who falls over 100 times, the person who falls over once. And so I'll sometimes I'll take it that far and talk about that with regards to what are the risk factors of, because that's what that's what most people are worried about, is the obviously either sustaining a fracture or sustaining another fracture. So I steer it towards that rather than worrying too much about what's actually happening in the internal components of their bones.
Grand. Okay, so Florence has walked out the door happy. She's happily awaiting her cylindronate infusion in a few weeks' time, or however long it's going to be. Let's keep you in, if I say you're still in a primary care position, and you've then seen what we'll call 55-year-old John with his persistent right medial knee pain and stiffness, and you've assessed him, and you've diagnosed that he's got osteoarthritis of his knee, right? And you tell him this, and he goes, okay, it's what I was expecting. And he says, so it's wear and tear then? What do you say?
My first question is, what do you think that means?
Okay.
I'll say, I'll say, okay, what do you understand by wear and tear? What have you been told? What do you think's going on in your knee? What do you think osteoarthritis is? And most times they'll say, oh, I've used my knee a lot. I played a lot of football. And the cartilage has worn away. And I'll say, well, what do you think is going to happen? What do you think is going to carry on happening? And if he says, well, if I do the physio, then that will stop happening and I will be better. Will I really address, like, if he's got a fairly positive outlook? I don't know if I'm getting bogged down in bothering. There's quite a lot of work to unpick. Yeah. At that point, am I getting bogged down if he's got a positive outlook? Maybe not. Maybe not. If he says, oh, if I keep using my knee, it's going to get worse and worse and worse, I'm intervening at that point. And I will often, I said I don't use analogies. I will often use an analogy like a straw man. So for example, with a car tire, and I'll be like, so if you've got a car tire and you drive it more, it will wear down. That is not what your knee is like. Your knee is a living structure. We replace the cartilage over time. There's all these different components that impact on not only what the knee looks like on the inside, but whether you are symptomatic. So those two things are separate. And I use this, I say that so many, I don't tend to use the, structure doesn't equal pain or damage doesn't equal pain. I don't tend to say that, but I'll say there's a big difference between what your joint looks like and what your symptoms are. And some people will have the worst looking knee you've ever seen and no symptoms. Other people have perfect looking knee and lots of symptoms. And actually at this point where we are now, it doesn't really make that many odds, assuming he's not got some absolutely completely annihilated joint. But and I'll say, look, it doesn't matter what your knee looks like. You've got just as much likelihood of improving as someone with a pristine looking knee. Yeah. We take you through the same process, and you've got the same likelihood of improvement. And so I would say to a healthcare professional, I think you're incorrect using the term wear and tear. I don't say that to the person, but I'll give them some slightly different narratives to try and get them into a more positive belief system around what's going to happen. Because I know I've had these patients before. There is no way, if I refer someone to physio and they think using their knee more will make it worse, physio's got no hope, or whatever MSK clinician I send it to. They have no hope. They're never going to get, either they've got to unpick it or they're not getting anywhere. So you have to start that narrative. And it depends a lot on the individual and what's happened to them, and why they're in the clinic and what they're doing now. But I used to, when I was younger, I was much more confrontational with my patients than I think was appropriate or necessary, and I learned my lessons quite rapidly. And you don't need to be at all. And yeah, just directing them towards a more positive narrative is a better option.
I mean, as has been suggested, and I've heard it and I've been using it myself, the term wear and repair now instead of wear and tear. Obviously, this is still OA stuff, and all the change in how we view it as now, from now wear and repair compared to wear and tear. Obviously, it's taking its time on getting through the healthcare system and people saying it. Is there an easy way, because there's going to be people listening to this and who will be seeing these people who have been told probably that, yes, you've got your knee osteoarthritis, it's wear and tear. And it's just been left like that. It's not been elaborated on. Let's say they've not been scared, perhaps. It's not been told, if you're going to wear it out, but they've just been told that and that's it. Or that's just how they've interpreted it. They may have just been given an x-ray result and they've assumed that. Is there a easy way that you've found? And let's say someone's, they're not anti, what we'll call, I'm doing air quotes here, conservative management or non-operative management. They're not fully bought in either. They're very much in the middle. Is there an easy way to help them that shift from wear and tear to wear and repair?
Yeah, you see, I'm not that enamored by wear and repair either.
Oh, okay.
Part of me thinks that it's just a different rhyme. And just because it rhymes doesn't make it useful. I also am not that enamored by age-related changes. Because I just think it very quickly leads you to you've got the knee of a 90-year-old, or that's what they interpret. So I don't use any of those. So the way I describe it is I usually use the word mismatch, but it's a mismatch between the amount of cartilage the knee's the easiest one, the amount of cartilage that you reabsorb versus the amount of cartilage you lay down. It's a mismatch there. So what's happening is you have a certain amount of cartilage, and just like your skin comes off, that's what creates household dust. So do cut layers of cartilage. And as they come off, you replace them with new ones, with new layers. If you have a mismatch between the speed or the quality, then what happens is you start to get thinner cartilage, or the cartilage starts to have crevices in. So if so either one or both of those things will happen. So you might get grinding, if it's not as smooth, or it might start to thin, which is what the early sort of stages we see on an osteoarthritic on an X-ray. And things progress from there if you continue with that mismatch, or if that mismatch is particularly fast. So then what that leads me to is the discussions around how do we address that. Okay, so loading, for example, stimulates the quality of the density of the cartilage. It's not going to thicken it, but it stimulates the quality of the cartilage. So then we can talk about exercise and loading being beneficial because it's going to stimulate that. The other thing is that then leads us into the systemic factors which are related to osteoarthritis. So why would having diabetes make you more likely to get osteoarthritis? Because your body is in more of an inflammatory state, and that speeds up the resorption of the cartilage. So you get the mismatch. So it leads you down different conversational levels. And again, I don't feel like that takes too long, and I feel like people can understand that. You can still use the injuries still are relevant. So the injuries will either damage the cartilage, or in injuries which don't, they cause a big inflammatory insult to the joint. So you get this rapid loss of cartilage. Surgery is the same. So people with an ACL tear, if you have your ACL repaired, you are still likely to get osteoarthritis. So it's not the loss of stability that's the problem. It's these inflammatory insults, and the surgery gives you another inflammatory insult. So you build on these layers again. Like, didn't mean to say that. It's like the cartilage, you build the layers. And so it's about a bit like the bone density thing. We're not going to regrow the cartilage. You can't do that, but you can increase the density of the cartilage, so it will shock absorb better, and it will stop that force being transmitted into the bone. But the other thing is that you can improve the tolerance of the joint. So you're going. So, and I use smart shoes. I'm barefooted now. I work at home a lot. I almost never wear shoes now. I wear trainers when I have to leave the house, which is as minimal as possible. Go to Sainsbury's, I put my shoes on. if I wear my smart shoes, which I know are upstairs in a cupboard, I've got to go to a wedding, my feet will hurt. Are my feet damaged? No, it's just I'm not used to wearing them. If I wore those shoes for a bit and built my tolerance up to those shoes, I would be able to wear those shoes. So the same thing happens at the joint, is you can build the tolerance of the joint up, and and how we do that is purely individual. So I feel like those. Whereas if you talk about, I get wear and repair, but you've still got to talk about a mismatch. You still have to have the similar conversation, because, well, if I'm wearing my joint but it's repairing, then why have I got osteoarthritis? Well, because the repair's not good enough. Well, so there's a mismatch between the wear, whatever that is, and the repair. So how do we stimulate the repair? We do we do this and that. So I can see why people use it, but my point would be, I suppose, why introduce it? Why introduce the word wear? Yes, wear happens. Yes, if you use your joint, the turnover of the cells might be slightly increased, but you stimulate the creation as well. So the loading, it's only, the recreational athletes don't get more osteoarthritis than sedentary people. They actually get less. It's only elite athletes. So if you're paid to be an athlete, you get osteoarthritis. But so it's most people, it's sort of an irrelevance. Occupational work, different to recreational activity. But that's because it's different stressor. It's not necessarily the load. So it's about understanding these different drivers. And I really would want people to start thinking of osteoarthritis as a metabolic problem rather than a joint problem. That's where the hard science seems to be going. And it's about, how do you set that conversation up? Because I still feel like if you're talking about, it's wear and repair, and you go, well, how do some of these other systemic factors, why are people with lots of abdominal fat, why are they much more likelihood to get thumb osteoarthritis? That's not to do with wear. Do you know what I mean? Yeah. Okay. It might stop the repair, but you're not some of those people don't load their hand at all.
Yeah. Yeah.
And so you can very quickly get into a sticky location. The knee is easy because that's the most obvious with loading.
Yeah.
And you can quote all these things it's 4 times body weight through your knee, and we lose 1 kilo and it stops 4 kilos through your knee, like loads of stuff. But then it's like, well, what happens at the shoulder then? It's like an inherently non-weight bearing joint. What happens at the thumb? These are common places to get osteoarthritis. The hip is a really fascinating one. You're more likely to get hip osteoarthritis if you're overweight. If you lose the weight, it helps knee osteoarthritis, but not hip.
Okay.
So you very quickly, I believe you very quickly can run into problems and I'm a fan of using similar narratives for everybody, so you don't get bogged down in talking about all these different things and getting confused and messing up your analogies or whatever, because then it just loses confidence in you. But I think it's important to try and understand that, and it's, I'm not suggesting it's easy to deliver some of those narratives, but I think the outcomes are much easier once you get into the treatment side of things, and how you describe how some of your treatments might work, and how you convince someone to lose weight without them thinking it's just because I'm overweight. That old chestnut.
They need a why, or kind of I call it a what's in it for me, so to speak. Most people need a reason why whatever you're suggesting is going to help. And actually, you said that about helping the cartilage density. I think obviously we've got no data on this yet, but I feel that would help more with buy-in and like people being on board with the why, compared to us saying it won't change the structure, but it will support. And actually, if we're given, most people will think about osteoarthritis with their cartilage. Even as you say, if we can't reverse, let's say, but we can improve what's there, that seems more optimistic as an explanation than what it used to be.
And I think it counters nicely counters without being confrontational if you use your knee, it's going to be worse, because we know that's not the case. We know that using your knee is going to be better, or your joints are going to be better, and not using them is going to be worse. So and that's the problem, is we need to increase people's activity levels. And you think about the other, we're seeing younger and younger and younger people getting osteoarthritis, and they have active jobs. Like, imagine how are you going to convince a postman or a builder they need to do more activity? And I go, I sometimes I'm just like, look, your occupational activity doesn't count. And I'm sorry that it doesn't, but it's a fact of, like, unfortunately it doesn't. And we need to be doing, and I talk about the intention to exercise. I go, it's like you have to have this intention to help your problem. And that's sort of the key component. So it's like, this is my, in inverted commas, treatment, that I'm setting some time aside for this. I'm sure there's psychological reasons for it that you can probably describe far better than I can, but it's like, this is my rehab time. And it might look similar to what your job is, like the postman, for example. It might look similar, but it's because it's not your job, it's going to be helpful, because there's a lot more other things going on. And again, it's like, well, if you've used a purely mechanical model to describe what's going on at the joint, and you've not gone metabolic systemic, how do you convince a postman that they need to do more walking? You're never gonna, they walk far more than you ever do. Do you know what I mean? It's like, well, I need them to do that. So it's difficult. It is difficult, but you have to find these ways around. And that's where I feel like the aiming to get to as close to what is actually happening at the joint as possible with the description helps you, because you're using the same narrative. Otherwise, like you say, what are you gonna, if you're using wear, it's unstable, so it's going to wear more, and so we need to make your knee more stable, but that's using the knee, it's going to wear. Well, what happens whilst we're doing that? So you're going to make me do stuff on my unstable knee? Well, yeah. But it's, it's not going to be stable immediately. So what do I need? Do I need a brace to hold it stable? Well, actually, a brace would help, but because we're going to offload, it's different. It's not going to, the knee, it's not going to hold you stable. It's going to do something else. Suddenly you're into all these other descriptions, which you suddenly have to describe loads of different stuff rather than following one narrative.
And I was just thinking about, this is slightly off topic, but you're thinking about, as you said, aside from the professional athletes, the ones that get paid, otherwise, regardless how much activity you did, I can see, as you were talking about, there's one group who I could think going about, and I'm just thinking there may not be any data for this yet, but you talk about being paid and being athletic, the gym class leaders who are doing, I don't know, how many gym classes and jump, all that stuff. Do we have anything at the moment, or are we just class them in the same boat as the non-athletes?
Yeah, I don't know specifically, but I would consider them more sort of similar to someone like a builder, or someone who has a heavy manual job. And it probably depends what type of classes they're leading and how repetitive they are or how heavily loaded they are. But and so I don't know would be, but if you think about those kinds of people, they're also confounding likely to be very health conscious. So they're likely to be like, right, I've got my meal prep done. I've got, because aesthetically that probably helps them. Whereas builders, they live on tea and biscuits and what have you, and then go to the pub afterwards for 3 or 4 pints. So I suspect there's a slight difference in them. So yeah, and it's, they probably fall between the gaps a little bit. But I suspect the builders who are extremely health conscious don't get the same, and you'd have to split them into groups, but you wouldn't get the same levels of osteoarthritis as the builders, who they're strong as hell, but they also drink 4 or 5 pints every day and smoke and eat pasties and what have you.
And so we're using that, as you discussed about the helping the cartilage density. You discuss your management plan. He's on board. Before he goes, he says, "Do I need an X-ray?"
Knew you were going to ask that.
He's not pushing for one. He's not saying I need
No.
one. He just says, "Do I need one?"
No. The answer is no. Yeah, you don't need an X-ray. Your clinical symptoms, the way your knee looks and the symptoms you're describing are typical of osteoarthritis. There's no indication for me to think something else is going on, that even if there was something slightly different, that wouldn't contain the same management program. And then if they're a bit hesitant, sometimes I'll go, look, you don't have lots and lots of redness or swelling that might indicate, an infection or an acute injury. You didn't fall down the stairs. Sometimes I'll go into some of the indications that might warrant me a image. Or, I work in rheumatology. I'll say, look, you don't have a family history of other types of arthritis. You don't have psoriasis. You don't have ulcerative colitis. So I'll give them some of my reasoning if they're a bit hesitant on that. So those are relatively easily avoided, in my opinion.
Yeah, I think if you can, again, the why, if you give them, and most people are on board with that. I think obviously it gets more challenging when they're pushing for it, but we're not going to worry about that today. Now, you and everyone else will be relieved to hear I'm not going to ask you how you answer questions on every individual rheumatological condition.
Yeah.
But I guess this is, before I give you a scenario, if this is a generic, let's say primary or secondary care, someone's just come in with whether it's spinal pain, and obviously most conditions for musculoskeletal pain aren't inflammatory. On the whole, inflammatory is 5-10%, something like that. At what point when someone's talking would you think, oh, I better ask these seem like I should ask the inflammatory questions? Are there certain bells that will go off, whether it's the morning stiffness, whether it's the worse at rest? Are there certain things that you go, okay, maybe I should ask these at this point?
Obviously, I see a biased set of people, so I ask them all the time. But I on what I teach is, so I think we should be asking the comorbidity questions for anybody with spinal pain, anybody with tendon pain, anybody with insidious onset joint pain. I also think you ask about 24-hour pattern. I assume most people ask about 24-hour pattern. So you're looking for waking in the night. But it's about the answers triggering you, and then the weight you put upon those. What is it like first thing in the morning? But it's the follow-up to that. So my job's easy. When I see second opinion stuff, it's pretty easy because people do 90% of the work for me, and then I just do the last bit. So it's like, are the symptoms worse in the morning? Yes. How long for? That's the follow-up question. So is it 5 minutes? Is it half an hour? Is it an hour? And people go, oh, it's quite a while. No, I need amount of time in, is it? And I go back 2-3 times and go, if you had to tell me that this morning, how long did you woke up at what time? When did your symptoms start to feel better? At what time? I need a time period because I need to start cutting off somewhere. 30 minutes is I tend to cut off at, but 60 minutes is sort of within the guidelines, really. So it start to cut off. So it's following that up. And then, so it's not that I'm like, there are occasions where you go through an assessment and then you get to a point, you're like, have you got, any of these conditions, ulcerative colitis? And they go, oh, yes, I do. And you go, I'll go back to some of these other questions and clarify because I wasn't thinking that at all. So that might happen, but I think it can be part of the normal assessment process. And as I said, I think we're asking all the questions already, but it's about flagging the symptoms when they come up. It's similar to, I always think when I did MSK, when I was a much younger clinician when I first started in MSK, and I was absolutely horrendously paranoid about Cauda-equina syndrome. And so I'd do my assessment, and I get to the end of my assessment, and I go, any numbness, pins and needles, you know, any trouble going to the toilet, like, it's tacked on at the end. Yeah. It's like, it feels weird. It feels tacked on at the end. Whereas when I was a bit later on and I was seeing sort of more complex spines and stuff, it becomes part of your assessment. And then you're not, you know, this sort of theory, this sort of idea that you're screening, you know, oh, I'm screening for Cauda-equina. It's part of your assessment. It's part of your, you know, if you're seeing someone with back pain, that's part of your assessment. And I'm the same thing with rheumatology. If you're seeing someone with tendon pain, that's part of your assessment. If it isn't, then you need to work on that. You know, my sort of the way I think about it. And then it's flagging, and then you sort of reach a threshold where you go, okay, I need more information, or I need investigations, or I need an onward referral, etc. And I don't, does that make sense as a distinction as to how you might go about that? Because and it comes from, I assume, and I think back on my own career, it comes from this place of wanting to get everything correct and get everything done. And you know, I don't know what everybody else was like, but you know, the note sheets, and they'd have like subjective and objective and past medical history and drug history and all these other things. I have a blank piece of paper now, and you know, I think it was Mike Stewart when I did some of his learning and he would talk about, you know, you have a conversation with the, it's not, you're not following this sheet of questions. That's not clinical reasoning. It's you have a conversation, and where does the conversation go? And the more experience that does help, the more, you know, patient mileage. And if you've only seen 5 patients, that's far more difficult than if you've seen 500 patients. But you get into this process, and it becomes infinitely easier the more specialized you are, because you know, I'm not seeing people with potentially who have diabetes. You know, FCP is so much more difficult, you know, than you know, from that kind of point of view, where you've just got this huge possibility, and then you have to narrow it down. But comparative to what I do, where it's like, I've got a referral, does this patient have psoriatic arthritis, yes or no? That's such an easier conversation for me to have and follow. But I think, you know, trying to, you know, you try to tick off these boxes. Oh, I need to have asked these questions. I need to have asked this. And it's like, well, a comprehensive assessment would include those. You follow it and you smooth. And once you get to that, and I remember sort of, you feel like, oh, I didn't used to feel this confident in my subjective assessments. You realize that you're not following this regime or this sort of questionnaire type deal. You're inquisitive as to what, because you have the confidence to know, and you remember, you know, oh, they said this, I'll come back to that for more detail. They, you know, whatever. This flagged. I've said my note. I've probably, oh, it's going to blur out on the screen. It's going to say, I'll show you what some of my writing is, just like a spider map of awfulness. But
you still do it on paper?
They're just details. I do, yeah. I can't talk and type. It's horrible. I type it up afterwards, but I want this. I want the AI software that writes your notes for you. Yeah, that's what I want now.
One day it'll come. So let's say you have suspicion, right? They're saying they got stiffness in the morning for more than an hour. They're saying there's pain at rest. They even get in multiple joint pains. The triggers have gone off. There's the additional questions. So you and I both discussed the screen dem tool in the past, or there's other ones out there. So you can the additional things like the inflammatory eye disease, the inflammatory bowel, all that stuff. When to ask? Would you ask the moment they start triggering it? Would you then go, well, I'm going to jump to these, or is there a better place you found to put it in?
So again, I try to follow their narrative as to what they're talking about. So I'll quite often say, and again, I'm lucky. I work in private practice. I have an hour to talk to these people. So I'll say, I tend to start off going, tell me what's going on. I'm super open. Question, what's happened? You know, where are you at? Tell me why you're speaking to me, those kind of questions. And I just let them go. And then what I'll do is, as I jot things down, I'll circle them to come back to. And then I tend to do it just because it's the way I've written it down. I tend to come back to them in the order they've gone down, unless something is particularly of interest to me. So, oh, my dad had arthritis, you know, okay, what kind of arthritis did your dad have? Because it's about, when you've done it for a while, it's like, what is going to narrow me down? What is, if you talk about the morning stiffness, they go, oh, I've got morning joint stiffness for 2 hours or 3 or 4, I don't know, a long time. Does it matter to me? Is it going to narrow down my differential diagnosis if I know it's 2 hours or 2.5 hours? No, it's well over the threshold. It's flippant to say I don't care. It doesn't matter. It does matter what type of arthritis they had, their family history is, because that narrows me down to different types. Do you know what I mean? So I'll go for the big stuff first. What's going to narrow me down? What's going to give me more information? And then I might go back to how long does that morning stiffness last for, more specifically, especially but then the flip side of that is, if they go, oh, the morning stiffness lasts half an hour or so, then I want to go, right, okay, now I'm differentiating between an autoinflammatory disorder and osteoarthritis or something else, or tendon pain or whatever. So, okay, now I'm going to go and narrow that down to, is it 15 minutes? Is it an hour? Be specific. Like, how specific can I be? Those kind of, so it's about picking the target in the individual. And I have to, cop out and say, a lot of that comes with experience as to how the patient sort of sounds, how their presentation sort of feels to you, on the basis of seeing quite a few of them. And there is a sort of, to quote Jack Chew, there is a sort of je ne sais quoi to having heard a lot of that before, and being able to fit the pattern recognition. I would think it's rare for me to go at the end, be like, oh, let me just ask you about whatever. Like, there is a natural flow to it. So, like, for example, family history, I'll ask them about, I'll get to a point where it's like past medical history, drug history, etc. Family history is part of that. So have you got any problems with your eyes, bowels, skin? Have any of your family members? So it's part and parcel of that, if that makes sense. But again, it's because I'm seeing this sort of narrowed subset of patients. It makes that a bit easier. It's not like, oh, I wasn't expecting that answer, and then come back to it. But then you do sometimes get that. So how many people have we ever asked, do you have diabetes? No. What drugs do you take? Metformin. Okay, let's go back. That's not an uncommon situation to occur. So sometimes that does happen. Or for example, my patients, a good example would be, they don't know their family history. They go away and then they come back and go, oh, my uncle had osteoarthritis, I just never knew. And you go, well, actually, that's quite a lot of information I didn't have previously with regards to family history. That changes some of the questions I might return to that. So sometimes it does happen, but mostly I think if you can do really good comprehensive assessment, it shouldn't be, oh, I'm now thinking about inflammatory stuff, because you are as it unfolds, if that makes sense.
Okay. So I'm thinking of that person we're talking in primary care or even secondary care, but pre-rheumatology. This is interesting from your side of it. What if someone's got a suspicion, they've got enough of the answers of what they've heard there to suspect there may be something inflammatory going on? What would you advise they say to the person at that point before they are seen in rheumatology? Because obviously, they're going to get the first specific diagnosis.
So prep them for the referral.
Yeah, I guess you say, make them aware, but without scaring them, or what would you ideally like them to say?
Yeah. So what I say is, I use the word suspicion or suspicious, and I go, look, the symptoms that you've described to me, they are to me suspicious of insert type of arthritis. And these are the symptoms that make me suspicious of that. So I will often parrot back to them, you know, your spinal stiffness lasts for 2 hours in the morning. Disc bulges or whatever, I use that in inverted commas if people aren't watching, don't cause specific spinal stiffness for 2 hours. So those things are suspicious to me. That does not mean at this point we are diagnosing you with something specific. What I would like is the opinion from the rheumatologist who specializes in those kinds of conditions, so that if you do have that type of arthritis or that type of condition, they can, as quickly as possible, get you onto the management strategies that will give you the best outcome. Some people, I'll go as a further reassuring method, I'll say, look, the good news is, and I'll pick out their presentation parts that make them more likely to have a good outcome. So typically a lot of my patients are female axial spondyloarthritis patients. So I'll be like, you know, you're young, you're female, that means you're less likely to get the structural damage that you might see on the internet. So I'll pick out components of that, or quite commonly I'll say, you know, you're doing a lot of the right things already. You're healthy eating, you don't smoke, you know, these kind of things. So you're gearing yourself up for positive outcomes, if that is the process. And that also leads me then into the conversation of, look, you're already doing these good things. Here are some other good things that you can do, that should it be that you're already progressing into a better outcome, you're giving yourself the best kind of outcome, even before we get some type of differential diagnosis. And then I'll commonly finish with, at that point, if they decide that it's not this type of arthritis, and then there's a few different things, you know, either I'm not the best, well, this is where you would go for more assessment, more intervention, or you would be reassured that it's not, and you can go and see physiotherapy or whoever you want to see, or have, you know, or come back to me and we'll relook at it if it is for me. But my situation, it doesn't tend to be that, but I try to leave them with the not the hope that it isn't that type, because obviously I'm suspicious that it is, but it's like, well, if it isn't, this is what we do. Because, you know, you working with we work with those patients with long-term disease, fibromyalgia being the classic one. I got referred to rheumatology, but they said it wasn't that, and now I'm in limbo again. And you same with hypermobility type patients, those, you know, those kind of people, you just end up in this cycle of someone thought it might be this, so they did an investigation or they did a referral, and then nothing else happened. You're like, you just leaving those people out on limbo like that is, they'll worry, what if it isn't that, what if it is that, what if it isn't that, they just worry the whole way. I think trying to reassure them in both directions is a good thing to try and do.
And let's say they've seen you've, now I do still see this, people get a very generic diagnosis of inflammatory arthritis.
Oh yeah, I hate that.
But we're not going to ask you to explain how you'd explain each individual one.
Okay.
But if we say the generic RA, the spondyloarthropathies, those that fall under that banner, not the connective tissue or more obscure stuff.
So autoinflammatory, you want autoinflammatory arthritis description.
Let's say they've been diagnosed RA, right? And she gets a diagnosis, but obviously it's been a few weeks. She gets referred somewhere, whether it's physio, whether it's back to GP somewhere, and for whatever reason they took the news, but classic Breaking Bad news, they couldn't remember much what was said afterwards. And they turn to the clinician, and like with the two conditions prior, they say, what does this mean? And let's say they don't know much at this point.
Yeah.
What's someone average understanding? What would you say for what that means?
Yeah. So rheumatoid is the easiest one. It's fair, but it's fairly interchangeable for the spondyloarthritis. You sort of need to know the target. But rheumatoid arthritis is the easiest one. So I'll go, you know, your peripheral joints, typically the knuckles, they've got a balloon type structure around the outside. What that does is it lubricates and feeds the joints. And what in rheumatoid arthritis, what's happened is your immune system thinks that that balloon structure isn't you. So it's a dysfunction with the immune system. This is an autoimmune problem. Most people will get that. It's an autoimmune. So it is, for want of a better phrase, attacking, and I'll inverted commas that or I'll use reacting, is reacting to your tissue, in this case the tissue of that balloon structure, and that is causing inflammation at the joint level. So at that joint you are getting, so inflammation isn't necessarily the problem, that's the outcome. The problem is your immune system thinks that bit of you isn't you. So that's why you need medication. Because I get a few people come and go, oh, do I have to take methotrexate? And I go, and this is what I sort of say to them. I'm like, look, it's the immune system that's problematic. So you need something to interact with the immune system to reduce that aggravation against the joints. So that's how we do it. And then again, it's like that, what we were talking about earlier, that leads me into systemic features of inflammation: sleep, stress, weight, diet, smoking, so on and so forth, because we've talked about that. This is being driven centrally. It's not a problem with the joint, it's a problem with the immune system. So things that we do, and that's why it's different. That's why it doesn't seem to make sense. So like, you know, the spinal patients, for example, with ankylosing spondylitis or something, I've got back pain, but if I go to the gym, I'm better, which is way different to my friend who, whatever, Jeff, who is far better laying on the sofa. And I go, well, yeah, because you don't have your back is not the problem. Your immune system is the problem. So you've got this dysfunction in your immune system, but that also then leads you into this, it eases you into, you asked about cure. Is it curable? Well, unfortunately, no. So we can't undo the dysfunction of the immune system, but we can manage it. Some people go into remission. You are more likely to go into remission if we treat it early, if you do these healthy things, if you exercise, eat the right stuff, don't smoke. So I try to use that to springboard me into the positive, if that makes sense. So no, we can't, but this, and this. And it's, so you have to have some kind of, you have to have a decent understanding of what is going on with these conditions. And one of the things that I've sort of taken on board more recently is clinicians thinking it's a joint problem. It's not, it is a problem at the joints, but it is not a problem with the joints. Your synovium in rheumatoid arthritis is reacting normally. That's what it's supposed to do. It's supposed to become thickened and more active, create more joint fluid, become more leaky. So it's supposed to do, but it's been doing that in the absence of injury because the immune system's telling it to or causing it to. And then it's in this chronic inflammatory cycle because the immune system doesn't resolve itself. It is dysfunctional. What I realized is that people are going, well, you know, go to stability again. Well, if why does giving hand exercises not stabilize the joints? It's like, well, because the joints aren't unstable until they become eroded. You know, that's not the problem. It's not a problem at the joint level. Now exercising, that has benefits, functional benefits, but equally exercising away from the problematic joint does, because you're reducing systemic inflammation. So in a flare situation, you can do other stuff. So you can use it to your advantage to still intervene as best you can, but it's sort of not a traditional, you know, rehab process, if that makes sense.
No, I think from experience, as you say, I'll do the air quotes as well, the immune system attacking itself, if you will, or attacking the joints. I think people, especially, you can read about it online and then get the handouts, whatever your information you're given, I think are generally able to understand it. And it gets more complex when you talk about, as you say, the various factors involved and how they influence all the metabolic stuff, etc. So, and again, I'm not going to ask you to go through all the connective tissue stuff, all the other stuff, because we'll be here for hours. That's another time. I will ask this with everyone, and when we arranged this, I told you I was going to ask, what are the hardest conversations you've had? And you told me there's two. One's infuriating and one's sad.
Which would you like first? I don't mind.
Let's go with the infuriating one.
Yeah. So this was back when I was a bit more confrontational than I am these days. And so the lady came into, I don't know. I was in rheumatology. I don't know how she ended up in rheumatology. I don't know how she ended up in front of me. She was not a rheumatological problem. It was, she had chronic low back pain, had done for 10 years. And we did the assessment, and she had never had an MRI. She'd had x-rays. She never had an MRI. It was very clear that she was very hung up on what the MRI was going to show. She was convinced that it would show what the problem was, why she'd had pain for however long she'd had it, and so on. And me being me at that point said, I thought it was a good idea to go, well, the MRI might not show anything, might show that there's nothing going on. Cue at least half an hour of back and forth about, well, I've got pain, I've got these issues, it's been going on for this long. Why would the MRI not show anything? And I could not get out of this cycle of me trying to, I'd sort of set my stall out that I thought it might not show it. And she was thinking I was saying it's not going to show anything, whereas I was trying to explain that it might not. I was trying to prep her because I felt she was very reliant at this point on what the MRI was going to show. And we just got into this cycle I could not get out of why do you think it's not going to show anything? And me trying to explain about structure and pain and central sensitization stuff. And it was the first time we'd met, and it was just way too much. And I should just not have gone there. I should just let her go and have the MRI.
Okay.
And because, I didn't know at the time, but her psychological issue was way outside of my skill set to deal with. And these days, I feel like I would recognize that it was not the time or the place or the correct appointment the first time we'd met to be doing that. And so that was very difficult. I was actually saved by a colleague that I'd probably still be sitting there 10 years later, had my colleague not come and interrupted and noticed what had going on and said that I needed to go and see my next patient, which was entirely not true, but got me out of the conversation. But it was just this, I don't think I've ever before or since gotten stuck in this cycle of just going round and round and didn't know what I said or how I tried to say it, that it just kept being worse, escalating back at me worse and worse and worse. And I didn't have the skill set to undo that. So that was the worst. That was probably the worst one. The other one was it was totally not my fault, but it shouldn't have been me delivering the information. So it was a pure, this happened and this happened and this happened at specific times that meant I ended up with the patient in front of me with quite advanced spinal cancer who didn't know. So it's just one of those things where the timings and everything it occurred. So I want to say the rheumatologist did the MRI. The patient he was older, I want to say mid-70s, and he had inflammatory sounding symptoms. He was very stiff, and there wasn't anything. He didn't seem particularly unwell. He had no past medical history. It was worrying. Nothing particular. You go back in the notes and you can see, he wasn't walking as far. He was feeling a bit more tired. He'd lost a bit of his appetite, but we see that a lot in rheumatology. It wasn't, nothing was standing out. There was, so the rheumatologist got the MRI. He'd also requested bloods, but he'd missed the bloods appointment, which would have shown up a lot of the bloods were, when he did get them, were all over the place. The MRI, he had the MRI. He happened to have an appointment with me for physio on the exact time that the radiologist reported the MRI. So he sat down in my clinic, and I knew he'd had the MRI. And as I knew he had the MRI, the report also came up. So I was there going, okay, I can report this MRI. I feel that's in my skill set. So the patient's sitting with me as I read, he's got quite advanced cancer. Yeah. So at which point I'm then like, is this within my skill set to deliver this news? You know, what am I going to do here? I actually also happened to have a student with me, which was another complicating factor to the whole thing. Yeah. So that was very challenging. So in the end, I sort of hedged my bets really. And unfortunately for me, the rheumatologist who had requested the MRI was next door. So I said to the chap, you know, the MRI has shown some things that I'd like the rheumatologist to discuss through with you. But which was fine. But the challenging part was he was then immediately worried because I was specialist physio, you know, he'd come to see me for his back pain. He assumed I was as skilled as was necessary to interpret that MRI. I think I'd even said, I've got the MRI results. I can discuss them with you. I think I'd even fronted that and then had backed off. Yeah, because I then read it because it flashed up as he was sat there, then read it and bricked it. So there was a bit of back and forth of him going, oh, what is it? Why? And me trying to be like, well, I can't tell him it's not bad because it's awful. I also I don't want to tell him what it is because I don't feel like it's within my, you know, the delivering bad news training. You know, I've had a little bit of it, but not, you know, to the extent that the consultant rheumatologist could deliver it. And in the end, I sort of had to shut him down a little bit and just be like, look, I just would much prefer the rheumatologist discusses this through with you. I've made sure to lock the computer. Explained the situation to the rheumatologist, who was very helpful, came in and basically took over my entire appointment for me. And I had no more to do with it. But I found that extremely difficult where you're trying to, you know, and I hope it doesn't happen to other people, but where you're trying to, this thing has happened and it is fairly terrible and it's landed on me, but it's not my skill set to deal with. And that was very difficult to do. And fortunately, like I say, the rheumatologist happened to be literally in the clinic room next door. And because I worked closely with him, he was quite happy to come and do that for me. But yeah, real challenge. And I think people want to be able to do imaging and they want to be able to do these skills, or, you know, again, in inverted commas, advanced stuff. And I don't necessarily think when you're a young clinician or a new clinician, you get the downsides to that, where, you know, either you're wildly off or something completely unexpected's happened or whatever. Bloods is another classic one where something random will come up. And it's, you know, it's just really, it can be really difficult. And I think we need to understand the gravity of that, really.
I understand, and please tell me, I'm not an imaging person at the moment, but if you order the scan, let's say, you are expected to be the person to tell them the results.
Correct.
So if you
traditionally, that would be what's happened.
If you had been the one to order the scan in that scenario, would you have been expected to tell him?
I think, you know, from a completely binary point of view, I think the answer would be yes. In that situation, it was outside of my skill set. And I think had I ordered the MRI, I would still have been in the same opinion. And we would have been, you know, look, hold my hands up. This is outside of my skill set to do. Go to a medical colleague. And again, I think we need to understand the limits. You know, we aren't doctors, most of us. We haven't done medical training, and we cap at some point. There are, you know, and again, in that situation, it's not even my area of specialty. You know, I've had some fairly bad imaging in rheumatology. You know, I asked for MRIs, X-rays, and I didn't think they'd be fused spines, and they are, or the osteoporotic fractures, for example. But they're within my skill set. At that time I felt to deal with. But then you move out of that area of expert, and this is the problem with moving into medical fields. You know, I'm working in rheumatology. I'm obviously not a rheumatologist. a physio in rheumatology, so I'm a physio with some of these rheumatology skills. So you have to know your limitations and know your limits, even if you are getting the imaging, you're getting, and you know, you have to think about within the situation that I was doing imaging. So, you know, I was seeing new rheumatology patients, but they were in suspected inflammatory spinal patients. So most not undifferentiated medical patients who still would end up with a doctor. So I think, you know, stratifying those kind of patients is useful, and making sure you're still within your, even if you're working above, you know, what is a traditional physio skill set, you still need to be working within your skill set. And unfortunately in that, there was, like I say, as you say, he should have had an appointment with the rheumatologist to go through those scan results. It just happened that the timings of all of those things conspired to be he was sat next to me when that got arrived. So sometimes you just can't help it. And I think, you know, you just have to be humble enough or know your limits enough to go, look, I need help with that situation.
We're a team, right?
I can't make that decision, or I can't. Yeah, exactly. And if you know, you've got to be, if you've ordered the imaging, then so I can see why there'd be pushback. But it's got to be a pretty harsh situation for someone else to have done the imaging and then be like, no, they're with you, you deal with it. That's very different. That I can't see being that helpful. And the teams I've all worked in before, you know, I've worked in orthopedics in what you would consider advanced clinical practice, listing for surgery and stuff. Same thing the orthopedic surgeon would have come and at least helped with that conversation when it's that severe, that significant. Because you and like you say, you're a team. They wouldn't leave their junior doctor to do it. I wouldn't have thought. They wouldn't. So why would they leave their physio to do it? And that's why they're consultants. That's why, you know, they've done a lot of training for a lot of years. They're extremely skilled. That's why they're in that position. That comes with a certain amount of sort of responsibility, I suppose would be the right word.
And thank you for showing those. I think it's very important, as you say, that it's, you know, we need to remember who's the scope, and also, things don't always go to plan. It's great to see people get better, but sometimes it can be difficult, and everyone has difficult conversations at times. I don't want to end this on a complete low. So there's one thing I think I wanted to ask, which is a difficult conversation you haven't had, but almost had. Could you take us back to how you were feeling back in May in the FA Cup semi-final, from the tweet posted earlier in the day to then Coventry being 4-3 up in that extra time against Man U? Could you just set the context for people that don't know what I'm talking about?
Yeah. So it was really funny. So I don't remember. Have you got the tweet in front of you exactly what I wrote or not? So I was off to I might have to look it up now to see what it was to give you the best thing. But so I was very lucky in that Jack Chew happened to have a spare ticket to the FA Cup semi-final. I live fairly easy access to Wembley, so I jumped on a train short notice. My brother we were supposed to be eating ribs with my brother, and I binned him off to go to the football. And off I went on the train with Jack Chew, who is a lifelong Man United fan. So Coventry were playing Man United, and I was stood in with all the Man United fans watching Coventry, hoping that Coventry would beat Man United, because they were if Coventry would win and beat Man United. But the tweet I think you're talking about is I said, if Coventry score, I'll give away an ebook to everybody who retweets. If Coventry win, I'll give away access to online course to a random selection of people. And then the problem was, not only did 85 people retweet it, but also Coventry scored 4. So people were then going, are you going to give away 4 ebooks? And I said, I'm going to be broke if I do that, so I'm not going to. But yeah, I gave away more than I should have in the end, I think.
That I'm just thinking how Jack's face as that obviously the cancelled 4th goal went in.
Yeah.
seeing all those free courses go away, and how he was feeling. You must have been that the moment that VAR call came out, you must have been the biggest sigh of relief in the stadium and all those Man United
I think it's one of those things where I think people would give you the grace that you aren't going to give away. What would it, I mean, what's the equivalent? Say it's 10 grand's worth of stuff, I suppose. No, I think people are going to give away, they give you the grace of that's not going to happen. Jack was sort of funny because he obviously wanted Man United to win anyway. He was also saying, I kind of want Coventry to win, so this tweet backfires, because the tweet was a joke at him. It wasn't. I thought Coventry would get steamrolled by Man United. In my heart of hearts, I thought Coventry would get steamrolled. The first half they were 3-0 down. They did get steamrolled, and then of course they come back from 3-3. The whole thing, best football match I've ever watched. Brilliant, absolutely brilliant to be in the atmosphere. It was unbelievable. And but yeah, so he sort of wanted it to go wrong to spite me, because the tweet was a spite at him. The whole thing was very funny. I never really thought this is going to go catastrophically wrong from a business point of view. I'll give away some courses, I'll make a joke out of it, and we'll be okay. I felt like the whole thing was done tongue in cheek, and I would get the grace of not having to give away 85 of my rheumatology courses at £150 each, because I cannot afford to do that.
Well, thankfully it works out well in the end.
It
again,
did. Yeah.
Thank you for doing this and recording it and sharing.
Pleasure.
Not just your wisdom, but also the stories as well. I'm currently looking at the Rheumatology Physio website. We've mentioned about the osteoporosis course. Obviously, the online rheumatology course is on there. How many ebooks now?
Oh, I don't know. I think this might be 11.
11. Okay. So 11.
Challenging well my memory.
Which I have some. For every, and not just talking rheumatology stuff, there's obviously some back pain stuff, there's hip stuff as well. So it's not just in those ebooks, specifically rheumatology stuff. Mentoring, I didn't know that. I'll just put the link in the description, but there is tons.
Wonderful.
Are there other things you'd like to plug?
Oh, everything's on the website. I have a Substack now, which has replaced my blog. So I did used to write a blog on the website, and now do it through Substack. That's quite good because it serves for everything. So I put my videos and my podcasts and stuff through that. So you can via I don't even know what the it must be rheumatologyphysio.substack.com, something like that. But everything's on their website. You can people will be able to find that. What else? What else do we do? Oh, anything Physio Matters as well.
Oh,
I'm sure.
We should say that.
Hopefully people have heard of that. You
can link that too. Grand. Anything else you want to say?
No, I don't think so. I think it's good to talk about. You've taught me quite a lot on a couple of webinars you've done about communication and considering how, because I've always been one for the facts will out. So if I give people the right information, that's sort of not sufficient, but it's a really good start. And I think I recorded with you about you were talking about use of tone. And I found that fascinating, and I have a lot of recording equipment, recorded myself talking and doing some different bits, and I can if I get into my flow, I can be very monotone is not the right, but it's almost a bit grandstandy, and I feel like I've since that I've tried to tone that back when I talk to patients and try to keep it more of a conversation, or as I did with somebody the other day who wanted a lot of information about something, and I said, look, I'm gonna talk, and I'll probably talk for a good 5 minutes. If you need to interrupt me because you want something clarified, please do. So try and give them the space to come back to me, because it's that thing, isn't it? I remember that picture of you're sat on a physio plinth looking down at your patient who's sat in a chair. You can be very authoritative. So I've tried to reduce that across because all of my appointments are online. And I think there's a lot to be said about communication. I think people will use rapport building as a bit throwaway. And they go, oh well, I asked them about, I remember that they've got a dog or whatever, and I think fine, but some of the stuff you've done has really helped me, particularly with sort of trying to keep the conversation two-way as much as anything else, and elicit the responses that we're looking for. So yeah, I'm really grateful for that. So thanks.
Thank you. Well, I'll tell you what, I'm gonna message Brad and Rob and about some of your thing, and if people want the rock, metal, physio, whatever, then they can message us. And yeah, thank you for listening or watching.
Perfect.
And we'll speak to people next time.